Most surgeons have one lingering concern about LET, and this new paper addresses that. It's the Sunday paper roundup where I read the literature so you don't have to. Lateral extra-articular tenodesis is being used more and more to augment ACL reconstruction, particularly in high-grade pivot shift and other high-risk knees. But a concern many surgeons still have is this: are we risking future osteoarthritis by potentially over-constraining the lateral compartment? And that concern isn't irrational. Biomechanical and imaging studies have shown early biochemical changes and small increases in lateral compartment contact stresses after LET. But importantly, those changes are small in magnitude and they have not translated into higher rates of clinically significant osteoarthritis and mid to long-term follow-up. Their true clinical relevance remains uncertain. So the key question this JBJS paper addresses is an important one. Does adding LET to ACL reconstruction change the long-term risk of moderate to severe radiographic osteoarthritis compared with isolated ACL reconstruction? This is a new JBJS systematic review and meta-analysis specifically focused on that long-term osteoarthritis question. Here's what they found, and this is where we go beyond the abstract. The analysis included 6 studies, 444 patients with a mean follow-up of just over 13 years. They weren't looking at short-term stability, they were looking at radiographic osteoarthritis over the long term. The headline finding was an actual reduction in moderate to severe osteoarthritis in the lateral compartment in patients who had LET added to their ACL reconstruction. That signal was seen using both Kellgren-Lawrence and IKDC radiographic classifications. Importantly, there was no clear difference in the medial compartment. When they looked specifically at knees that had meniscectomy, the apparent protective signal from LET was even stronger, which is clinically interesting given how powerful a driver meniscus loss is for osteoarthritis. Remember to save this if you want to revisit the evidence later. Now, a proper Sunday paper roundup means we also talk about the limitations. First, this is a small meta-analysis, only 6 studies and 444 patients, so confidence intervals are wide and individual studies can disproportionately influence results. Secondly, LET is not a single operation. Surgical technique, graft choice, tensioning, knee flexion angles and rehabilitation protocols vary across the studies, introducing heterogeneity. Third, many of the included studies are comparative cohorts rather than randomized trials, so confounding by indication is inevitable. High-risk knees are more likely to receive LET. And finally, radiographic osteoarthritis grading depends on the classification system used, which can influence the effect size. So this paper does not tell us to perform LET routinely in everyone, but what it does do is directly address one of the longest standing concerns in sports knee surgery. For me, the take-home is reassuring. The fear that LET can over-constrain the lateral compartment and accelerate osteoarthritis is not supported by the best long-term clinical evidence we currently have, and in selected patients, the signal may even favour protection. So as always, we finish with a verdict. Should we ignore it, be aware of it, really consider it, or change our practice? And my verdict for this one, really consider it. Not because this proves that LET prevents osteoarthritis in all knees, but because it meaningfully reduces our anxiety about lateral compartment osteoarthritis and strengthens the case for selective LET in the right patient. Make sure to follow along for next Sunday's paper. I'll keep decoding the evidence as it's published.